So, good afternoon, everyone, and welcome to today's webinar. We're exploring stigma and how it prevents consumers from accessing the healthcare that they need. My name is Elizabeth Devaney, and I'm the CEO of Consumers Health Forum of Australia, and I'll be your host today. As usual, our webinar will be recorded and you can re-watch it on our YouTube channel. So for those of you that have free time in January, you can watch it again and again. In fact, it's a great Christmas present. Why don't you put that in a link, send it to your family and friends and say, watch this. That's certainly an option. Why not? I'm just reminding you that also we don't allow AI scribes unless they're being permitted for accessibility reasons into our webinars. So if anyone happens to pop one in, you'll notice we'll pop it out. Thanks for understanding. We always want to know who's in the room and respect the privacy of everyone else that's here with us. So I'm joining today from Naarm, where it's a very important day because the Victorian government is giving an apology to Aboriginal and Torres Strait Islander people for the first time ever. Some of you might have watched the live stream from Victorian Parliament House earlier on. Yeah, thanks for the love heart. Feel free to share the love. It's kind of bittersweet, isn't it? It's really great they're doing it, but there are so many things to apologise for. And to be honest, we need to keep apologising because we haven't got this right. I would like to acknowledge that I'm actually on the land of the Wurundjeri people of the Eastern Kulin Nation, and I would like to pay my respect to their elders, past, present, and emerging. Note that this has always been their land, which they've cared for so carefully, and we have the great privilege of being able to be on today. I want to acknowledge and respect their culture and their contribution to the life of Naarm and, of course, most of Australia in many ways. I'd also like to particularly acknowledge any Aboriginal or Torres Strait Islander people who are here today. Now, as you can imagine, with a topic like stigma and discrimination, hi Annie Warren, lovely to see you here. This can be a deeply personal conversation and touch on people's lived experience. We do just want to spend a moment acknowledging the lived experience of everyone here on the call today. This particular statement was co-designed with our Consumer Assembly this year, and we're really proud of it. So I might just read it out loud for all of us, and we'll just take a moment. We acknowledge and deeply respect the lived and living experience of health consumers, carers, families and communities across Australia. We recognise the right of every person to equitable access to healthcare regardless of their background or circumstances. We value the lived experience, expertise and personal commitment of consumer advocates working to influence change. And we seek to elevate the voices of those who have navigated the complexities of the healthcare system and partner with them to drive meaningful and inclusive change. So I'd love to know how you feel about our acknowledgement of the experience. Some of you have already got those reactions happening. Feel free to show me, did you like it? Oh, a round of applause, thank you, a heart. No party poppers yet, but a few claps, terrific, keep them coming. So now we're on to the webinar proper. We're really proud to be hosting today's webinar on stigma and discrimination in healthcare. It's an important topic and an issue which impacts on the work and lives of arguably all of our member organisations and certainly many, many consumers. Stigma in healthcare is not a social issue only, it's a structural barrier which prevents people from getting the care that they need. When people living with a health issue are met with judgment instead of compassion, they delay treatment, avoid services, and often as a consequence, their health is worse. And this is unacceptable, especially in a country that prides itself on fair goes and equality. So breaking down the stigma is essential in order to ensure equity for healthcare. And we have to demand really that this happens. We want a healthcare system where dignity is non-negotiable, where health consumers are welcome without prejudice, and where access to care is determined by need. If you need it, you should be able to get it. So today we hope to talk to some of these issues. We've got some really great speakers from different CHF member organisations, and they're going to share with you how stigma and discrimination impacts on consumers in their communities, and also perhaps some of the things we should be doing to deal with this better. But to kick this off today, we're going to start with a poll. We often use polls in our webinars. And we're going to ask you a question that'll come up shortly on your screen about stigma and discrimination, and ask you if it's ever stopped you accessing care. So here it is. You can pop your answer, yes, no, or no, but it makes it harder for me. I'll give you a moment to do that. Great. So hopefully you've all had a chance to press that radio button. And we've got one more poll for you too. And we'll share this later on today. So we'll show you the results. This is asking you what you would like to be done to stop this issue of stigma impact on people's access to healthcare. There are a few options there. You can choose all of the above, one of them, or something else if you think what you think really needs to happen isn't on the list. I'll just give you a little longer. You might need to read through these and make a decision. Okay, folks. So I'm going to give you the results for the first poll just so that you get a sense early on of how we're tracking. So we asked you, does the stigma or discrimination in the healthcare system stop from accessing care? So more than half of you said yes. Another 20% said no, but it makes it harder. And only a third of you, or less than a third, actually said no. They're really strong results to start with and show why it's so important that we have this conversation. Now, if you haven't been here before, when we have these CHF Talks webinars, we want to hear from you. So we'd like you to introduce yourself in the chat. And there's some old hands who've already done it. Well done to those who have. So we hope that you use the chat also to share some respectful conversations during the session. Now, if you've got a question for one of our panelists, because we will have some Q&A time, then there's a Q&A at the bottom of your screen as well. So you can pop your questions into the Q&A area, and we'll do our best to get through them. To be honest, we rarely get through all the questions, but we really do try to. If we get a few that are similar, we might theme them up together. So if you've got a question, do pop it in. Also remember that you can express your reactions today using the reaction buttons. Some people have already found that. It's down the bottom in your toolbar. So you can clap, give a thumbs up, thumbs down, laugh, surprise, party. You can even send them with effects too, like love hearts and balloons, all kinds of things. So let's do just a bit of a check. I see someone's using one now. Well done you. We're a bit big on vibe checks at CHF. So we're going to just ask you to choose an emoji that represents how you're feeling today. So everyone, there's 65 of us, so I won't do it. So there should be 64 emojis now come up. How are you feeling today? So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23. Keep them coming. We're about halfway. There's no right or wrong answer. There's no bragging rights or prizes. Just press an emoji to tell us how you're feeling. We also like people to introduce themselves in the chat, and I can see that some folks have done that already, and that is fantastic. We love to know your name, how you'd like to be called. Sometimes whatever comes up on Zoom isn't your name. It might just be an initial, sometimes even a phone number, so put your name in there. If your name's Edwin, but you like to be Ed, let us know so that if you ask a question, we know to say Ed. We love to know your pronouns too, so we can respond respectfully to you. Let us know what they are. and where you are. So I see we've got some people from Boomerang Lands, we've got some people from Wurundjeri country, some Ghana folks, thanks, from Ghana country, Bolu as well, wonderful to see you here, some people from Turrbal and Jagera country, Meanjin, all over the place. It's Gadigal country too, terrific, lovely to see you. So great to see some Ngunnawal and Ngambri people from those lands as well. So Gubbi Gubbi, terrific. So if you haven't had a chance yet, really terrific for you to just put in, say, hi, this is my name, these are my pronouns, this is where I am. If you're from an organisation or you're here for a reason, you're welcome to share that too. Anything you like is welcome in the chat, as long as we keep it respectful. So you can pop all of that into the chat. So we're going to do a few things this afternoon. Firstly, we'll explain what might be meant by words like stigma and discrimination and what they look like in the real world. Then we're going to hear from our panel members who'll give a bit of a presentation, and then we'll have an opportunity for questions as well. So I'm going to start with what do we mean when we talk about stigma? And we've got a couple of slides here, thanks team. We've got a couple of definitions of stigma. I won't read those out, I'll let you do that yourselves. But you'll see they are different. In terms of how the Australian government defines it, this one is one that came out of a Prime Minister and Cabinet piece of work done more broadly on how people access government services, so it wasn't only health. It's interesting to see the two different ways of describing stigma. So in this case, with the department, the government one, we would say, well, what does that mean for how people get health care? Stigma is often rooted in community beliefs and biases about seeking help and deservedness, as you can see here. In other words, who deserves to get healthcare or other government services and who doesn't? Now, in that report, you can see in a lot of slides going to come that they talked about 4 different kinds of stigma: public stigma, self-stigma, stigma by association, so being part of a group, and structural stigma, which is often also called discrimination. And this report pointed out that stigma can negatively impact someone so they don't seek a service, which in health is really critical, of course. And you can see even those definitions and examples that things are similar, but also slightly different. I think the other thing to add is that sometimes people like to use specific terms, like talk about structural stigma or personal stigma. Sometimes people like to use more general terms. And there is also often a tension between using a word like stigma, which talks about how a person might feel. For example, they might feel shame. And words like discrimination, which talk about legal requirements. So it's illegal to discriminate. So if you think you've been discriminated against, you might have a legal mechanism you can put in place to stop that happening for you and other people. Whereas if something's done that perhaps doesn't fit the criteria of being a discrimination, it doesn't mean it still can't have an impact on you and the people that you know. So you find these terms, stigma and discrimination, used in different ways, and you'll hear that with our speakers today too. They'll use one or other of those words and use them, and they might explain a little bit about why they choose to use a particular word. We think there's room for all of that and probably more as well. So today, as we hear from our speakers, we're going to hear about stigma, we're going to hear about discrimination, we might hear about different kinds of that, what it looks like, what we can do about it, and how we can all help. So I would like to introduce my consumer co-commentators before we start with our presentations. So again, we try to have voices of consumers in the webinar in lots of ways. So all of you on the line is one way, but also by having consumers. And I can see them both there. Hi to Ali and Saba, who are joining us today. We're going to pop their bios in the chat so you can get to know them a little bit more. And they're long. I just looked and they went whoosh down the chat. You may need a cup of tea to read all the things these two people are doing because they're amazing and involved in so many different things. So have a look at all of that. But I might ask them to just to introduce themselves. To Saba, do you want to just give a little introduction first, and then I'll throw to Ali. Thanks.
Sure. So I'm Sabam. So I'm a rural consumer living in regional New South Wales with my young family. Also a very proud member of the assembly from the Consumer Health Forum of Australia. And just a quick reflection on the topic today. Um, so what I feel is it's a bitter truth, but definitely healthcare does not treat everyone with respect, dignity, and equality. And stigma around asking questions harms people and definitely delays the diagnosis, stop people from asking questions, and also it creates a lot of fear. I know personally I have avoided few consultations in the past because I had a feeling that I'll be judged. I had gestational diabetes in the past, and there were assumptions that because being from, and again, you can make out that I'm a migrant, so again, from a Southeast Asian background, definitely I'll be eating a lot of rice, which is not true. So yeah, definitely, you don't tend to ask a lot of questions because you always have a feeling that you will be judged, and also sometimes there is unconscious biasness as well, because I feel that there is a chance that the patient consent does not matter because the clinician or the health professionals have already made up their mind about your treatment plan. So and definitely there is a lot of stigma and discrimination in the healthcare industry, especially people from the ethnic background, when there is again a huge challenge of the translator and interpreter in the services. Thanks, Elizabeth.
Great. Thanks so much, Saba. And Ali, loving those brooches too. Tell us about yourself and a little bit about your thoughts about today.
Thanks, Elizabeth. So my name's Ali. I use they, them pronouns, and I'm based in Barron/Mount Gambier on Boandik country. I'm also a consumer assembly member, serving alongside Saba and many other wonderful colleagues. I have a background in disability and general consumer advocacy with a focus on youth mental health as well in the past. I've got lived and living experience of disability, chronic illness, mental health challenges, and a few other things too, just for fun. So I've definitely also encountered my fair share of stigma in the healthcare system and very much agree with everything that Saba has already said. So no need to reiterate what's been stated so well already.
Great. Thanks so much, Ali. Fantastic. Like you're giving a bit of love too. Thank you. Well, and we'll be talking to Saba and Ali during the rest of the session too. So now I'm going to introduce our first speaker, Lucy Collins, who's the CEO of the CHF member organisation Hepatitis Australia, and also just become a member of the CHF board. So she's doing double duty. I'm going to read out a short version of Lucy's bio, but again, the team will put her full bio in the chat so that you can get a better sense of her. So Lucy's done a lot of work working in peak bodies and has a track record of building strategic partnerships and achieving policy outcomes. That's what we like, someone that gets stuff done, Lucy. There's so much to do. She's worked for government with healthcare and researchers on health and medical research policy. Was previously a practicing lawyer and held key policy decisions in state and federal government, including serving as Deputy Chief of Staff for a government minister. So Lucy, I'm going to hand the baton to you and looking forward to your presentation. Thank you.
Thank you. Thank you, Elizabeth. Lovely to be here. Lovely to be on the board of the CHF and to be working to bring consumers and lived experience to all parts of our healthcare system, and something that we work on constantly at Hepatitis Australia. I am, as Elizabeth mentioned, the CEO of Hepatitis Australia. I have been here for a year and a bit, and I have to say, since coming to this role and working more and more in particularly bloodborne viruses and highly stigmatized conditions, I am absolutely astounded at the immense barrier to treatment and care that stigma presents for lots of parts of our community. So I'm going to talk specifically about viral hepatitis, but some of what I'm talking about I think will resonate with others with lived experience. I'm joining you today from the lands of the Ngunnawal and Ngambri people here in the ACT. I'd like to extend my respect to Aboriginal and Torres Strait Islander people joining the conversation, and also acknowledge the disproportionate burden that viral hepatitis places on Aboriginal communities. There's a lot of optimism, though. I think in that story, we see wonderful outcomes in the Northern Territory in hepatitis B through a program called Hep B Pass, which is presenting options for people in a range of community languages and overcoming some of those barriers of stigma by presenting work in language. So there's some serious challenges. There's some real reason for optimism in that story. I'm going to share a presentation, and hopefully the tech will all work beautifully. Is that happening, Elizabeth? I hope. Yes?
Yes, yep, we can see it.
Fabulous. Okay. So let's talk a little bit about what viral hepatitis is, because it's not actually a condition that's really well understood across the broader community. There are a few people in the audience who have very deep expertise. I just saw Jack Wallace, who is in fact a founder of Hepatitis Australia, pop up in the chat. But let's start looking at viral hepatitis. So 5 different viruses that affect the liver. Often you'll hear people talk about their lived experience of hepatitis A. That's often one that can be acquired food or waterborne. Often people will spontaneously clear hepatitis A. When we talk about viral hepatitis, we're very focused on hepatitis B and hepatitis C. There are nearly 300,000 people in Australia living with hepatitis B and C. The impact of those conditions is that the attack on the liver can lead to scarring. It can, in the longer term, lead to liver cancer, and 1,000 people a year die with hepatitis B and hepatitis C. These are conditions that really no one should be living with anymore. There is a vaccine for hepatitis B, and anybody who's 21 or younger in Australia will be vaccinated for hepatitis B. There's a very simple cure for hepatitis C, which is a course of tablets for 12 weeks, and you no longer have the virus at all. It's 95% effective. So the fact that anybody is living with either of these conditions these days is testament to the barrier that stigma really presents. And these are highly, highly stigmatized conditions. Let's start with hepatitis B. This is a resource that Hepatitis Australia developed earlier this year. If hepatitis was 100 people, so there's 300,000 people living with hepatitis, 220,000 with hepatitis B. And we talk about hepatitis B as being a family disease because it's often transferred mother to baby. It will exist often in family groups. It's very much a condition that impacts culturally diverse communities in Australia. 70% of people in Australia living with hepatitis B were born overseas. 56% of people with Hep B speak a language other than English at home. So we do a lot of work to make sure that we're presenting information on hepatitis B in a range of community languages. And I was really struck, Elizabeth, in the opening about that reference to from the Prime Minister, Department of Prime Minister and Cabinet, that definition of stigma being really rooted in community beliefs. And this is really what we see play out in the hepatitis B context, that law and public health messaging really differ across countries of origin for hepatitis B. And that really affects the cultural understanding of hepatitis B. And let's look at that in more detail, because there's some pretty amazing research out of UNSW, which community hepatitis organizations who are our members have contributed to, which looks at community attitudes to hepatitis B. And this gives you a sense of the stigma that people live with and why you might not want to put your hand up for a test for hepatitis B or come forward for treatment. So really, really widespread stigma around hepatitis B. 80% of people living with hepatitis B anticipate receiving stigma if they are diagnosed. A third of people in some community contexts will avoid close contact with people with hepatitis B because they're worried about transmission. And a reminder, you can't get hepatitis B from hugging or kissing or sharing food. You can very successfully live and work and migrate with hepatitis B, but we're still seeing that really strong stigma and misinformation happening in lots of contexts. And, this is something that exists in right across our community, and it can be very institutionalized, some of this messaging around hepatitis B. This is on the Department of Home Affairs website. This is a government website, and the heading on the website is Threats to Public Health. And you can see here, this website says if you have HIV or hepatitis B and you apply for a temporary visa, your condition might be considered a threat to public health. Imagine what it is like to be living with a condition and have a government website that says something like that about your condition. This is really institutionalized stigma. That stigma exists as well for hepatitis C. And there was it's a stigma indicators monitoring project that looked at stigma in the hepatitis C context, which they surveyed the general public. 2/3 of people surveyed said they would treat someone negatively because if they had injecting drug use. 1/3 of people said they would treat someone negatively if they thought they had hepatitis C. So you can see the huge stigma barriers people are trying to overcome here. But let's look at hepatitis C a little bit more closely. So hepatitis C in Australia is traditionally associated with injecting drug use, and it often has been transmitted blood-to-blood contact. So it can be through injecting drug use and the sharing of needles, for example. It could be through unsafe tattooing practices. It might be a blood transfusion back, in the 70s, 80s, before we had really good blood screening, overseas medical procedures. There's lots of ways that you can acquire hepatitis C, but because it's really associated with injecting drug use, that tends to be where we see the stigma around that sitting. And so on any given day in the hepatitis C population, about 16% of people are active injecting drug users, but actually these days that population is changing a little bit, and 84% of people might have acquired hep C injecting drugs once at a party 30 years ago. It might be through some of those other risk factors, previous tattooing practices, other things. But that bigger part of the hep C cohort might not identify necessarily as an injecting drug user. And so we have to find other ways of reaching that population and saying it's okay to come forward for treatment for hepatitis C, because it's completely curable and no one should need to live with hepatitis C. The impacts of that stigma are real. It is, one, creating a fear for people of coming forward for the treatment that they need, but it also really significantly impacts people's human rights. And we see that very strongly in the prison system. There is a lot of injecting drug use in every prison in Australia, and that puts people at risk of contracting hepatitis C in the prison system. Under international human rights law, people who are incarcerated are entitled to the same quality of healthcare as people in the general community. And people in the general community can access needle and syringe programs and clean injecting equipment. You can't get that in the prison system. And that's really another impact of stigma. Although I will say that there's lots of really fantastic intervention work being done by community hepatitis organisations and lots of other parts of the health system to make sure that we're doing good screening and harm reduction approaches for people, incarcerated people. At Hepatitis Australia, we've been doing some work to try and reach, as I say, that bigger part of the hepatitis C population who might want to come forward for testing and treatment. This is a campaign that we've been piloting in Queensland. I think I saw Michaela from Hep Queensland pop in the chat. We'll roll it out in WA next year. We've tried it in New South Wales and Tassie as well. And it's really targeting people who might have some of those historic risk factors for hepatitis C to say, come forward and get a test. And importantly, you don't have to say why you want a hep C test. Because if you're really worried about attracting all of that stigma that comes with hepatitis C, you won't come forward for a test. We know that. So you don't have to say why you want this hep C test. You can just say, I think I have some historic risk factors and I would like a hep C test, please. So in designing campaigns like this, we do need to be very careful not to re-stigmatize people. And there's research that says sometimes public awareness campaigns themselves can be stigmatizing. And that's a real challenge for all of us working in public health spaces. In this particular campaign, we did work with people with lived experience just to really make sure that we weren't conveying any message like, you used to be bad and now you're good. Anybody at any life stage, no matter what you're doing in your personal time, is entitled to good quality healthcare. So come forward for testing and treatment if you think you're at risk of hepatitis C. And, similar positive messaging around hepatitis B. You can live and work and migrate very successfully with hepatitis B. Hepatitis B is not a barrier to migration, permanent migration in Australia. So don't be afraid to get the testing and treatment you need. But we know that stigma still really does create a strong barrier in hepatitis B. 75% of people living with hepatitis B do not receive guidelines-based healthcare. 75% of people don't get the care that they're entitled to, and much of that is because of that fear of stigma to come forward for treatment. So, look, stigma is real. It has real impacts on the care that people receive. It really impacts the way that people come forward for care. It's measurable. When Australia has committed to a target of eliminating viral hepatitis by 2030, we can, as a nation, claim that we've achieved elimination of hepatitis if, one, we've achieved it equitably for everybody nationally. That means for incarcerated people, for Aboriginal and Torres Strait Islander people, for people from culturally diverse communities. We have to have equity of elimination in order to claim elimination. And so addressing stigma is a key part of that. But we also can't claim that we've achieved elimination until we have really, really addressed that stigma that people experience when they're living with viral hepatitis. And you can see that some of those targets in the new hepatitis strategies, which will be released by the government next year. That is a whistle-stop tour of viral hepatitis and stigma, and I'm very happy to take questions or have a further conversation. Thanks, Elizabeth.
Fantastic. That was a great presentation. Let's show Lucy some love, folks, and the reactions. And if you've got questions, that's what the Q&A is for. So look at all that love you're getting, Lucy. Pop your questions in the Q&A, and then later on we'll come back to them. Now I want to check in with Saba and Ali. I'll go to you first, Saba, and say what stood out to you in Lucy's presentation.
Very interesting presentation, Lucy. What really stood out was 76% of cases in the migrant community, which is so shocking. But also the public, the messages which really differs between different agencies and the states, that really stood out for me. Also, what I thought was stigma around the cultural and migrant identity, because I know it really affects the ability of the person to seek their treatment plans. That was really starting point for me, because I thought the conversation need to start. I'm interested to know, in case if somebody from the ethnic background, they really want to take that test, is it covered under Medicare? Because we need to understand that not everybody has got a Medicare, or is it Medicare exempted? And my second question is, I know when the refugees and asylum seekers, they come to the country, they have got their own mandatory screening. So I'm interested to know whether this particular test is added in that mandatory test toolkit or not.
Now, great questions. Yeah, so hepatitis C, B, and C tests are covered by Medicare. But you do need to ask for them. There's a bit of a kind of misnomer that it's part of routine blood screening. Yeah. When your doctor orders your thyroid panel or your iron test, they're not looking for viral hepatitis, so you do need to ask for the test. And in terms of migration screening, anybody seeking permanent migration to Australia will be screened for hepatitis B and hepatitis C. And then it's a notifiable condition. And so a public health unit somewhere is notified that there's a case. And we try and make sure that people at that point are being connected to care. That process of connecting people to care varies a little bit depending on what state you're in. Some places it's done extremely well. Some places it could be done much better. But Hepatitis Australia, in partnership with all of our members, community hepatitis organisations, runs HepLink, which is the National Hepatitis Information and Referral Service. So if you are a healthcare consumer and you're worried about viral hep, if you are somebody working with at-risk populations, you can send them our way and we will be providing stigma-free care for people and getting them connected to the services that they need.
Okay, perfect. Thank you. And one more observation which I had was around the campaigns and the promotion, because I thought that it's really important to have a culturally safe environment, and the campaign should be tailored around the ethnic community, because we need to understand that not all LHDs and all hospitals have got a multicultural liaison officers or a very dedicated team. So that's another barrier which I feel that really inhibits the promotion of all the materials. And again, some of the emerging languages.
Absolutely. And hepatitis B is a very intersectional condition. There's a lot happening in somebody's life at the point they're being diagnosed, because they're migrating and they're trying to find jobs and schools, and there's a lot happening. So we do make sure that we're offering resources in language. We'll launch a national hepatitis B campaign early next year, which has been funded by the Australian government, which will very much be delivered in language, and that's been co-designed with people living with hepatitis B. Some of our friends from Hepatitis B Voices Australia, which is a wonderful lived experience group that we work with often too.
Thanks,
Yeah.
Lucy.
And Sabra and Brett's mentioned in the chat too the issue of testing being paid for by a Medicare card, assuming you've got one. So for those people who don't have a Medicare card, then accessing the testing can be more challenging too. But I want to move to you now. I'm sure you've got some thoughts as well, Ali.
Thank you. So a few of the things that really stood out to me was just how deeply how deeply all forms of stigma continue to influence the experience of living with viral hepatitis, and how that misinformation around how it's transmitted and can be treated or managed is so prevalent in the community. It goes to show how much I am unaware of that. I thought it was less than it actually is still. And yeah, as someone else has noted in the chat, the fact that both HIV and hepatitis B are still treated as threats to public health was something I found very startling. Especially with HIV, we have treatments and management for that condition, as well as hepatitis B. So I really hope that that language is reconsidered.
Yeah, it's an enormous barrier to care. It's why 75% of people with Hep B don't receive guidelines-based care, I think, because sometimes people are afraid to put their hand up and come forward.
Yeah, because of that fear of being judged can be so intense and so crippling. So it almost activates that freeze response. But I really love David's reflection in the chat as well, where he notes that having lived for the best part of 50 years with Hep B and C, he's seen a lot of stigma reduction actually over the years. And a lot of that is the influence of community advocates, community-centered care. And I think that's a real testament to the wonderful work that people have done in this space and continue to do.
Yeah, and there's a lot of, drug user advocate organizations who've really contributed to that process, community hepatitis organizations. There's been a lot of community work done to try and alleviate that stigma. And slowly, we are making progress, but we haven't gone as far as we need to. Yeah.
No. And to quote from the chat again, Jack Wallace has said that being treated for Hep C had a massive impact on his personal experience of stigma because he doesn't have to disclose that status anymore. So, yeah, that's wonderful.
Great, thanks, Ellie. And chat, you're doing a great job. Keep it up, chat. We love everything that's in there. And we have started to get into that issue around stigma and discrimination. I'm sure in a moment Priscilla's going to get into that more too. This notion of the intersectionality, if you like, between those two words, because they have a relationship, don't they? People do experience discrimination, absolutely, whether it's unfair housing or access to care. But I think stigma has a part to play in the picture too. Discrimination is like an action doing something to someone, where stigma is about belief systems. And if we don't address both, then we can't solve the problem, which is making sure that people feel safe to get the care that they need. If you grow up in a family or a culture where certain issues are seen as, taboo or as inappropriate or as, perhaps even evil, whatever way people are thought, people can internalize that stigma and then start making decisions without even realizing what the consequences are. So these words are really interesting, and that's part of why we want to have the conversation today to talk about, well, is it stigma? Is it discrimination? What do we need to do? How do we call it? And how do we all work on this together? So it's really fantastic to have the amazing Priscilla Bryce along with us as well. They're the CEO of the National Mental Health Consumer Alliance, also a CHF member, and so fantastic to have your organisation up and running. A long time waiting, and I'm sure there'll be a bit of love and claps in the chat now just to say so great to have your organisation up and running. Again, another amazing person. Priscilla's done so many things. Her bio's in the chat, and yes, you'll need a cup of tea to read that one as well. She was previously the CEO of the Bean, which is a mental health organisation, and also has founded All Together Now, which is Australia's leading racial equity organisation, and done lots of other things too. So really happy to hand over to them now, and looking forward to your presentation. Thanks, Priscilla.
Thanks, Elizabeth. I'll just share my screen. Oh my goodness, I have so many screens open now, I can't find it. Here we go. Can you see my full presentation?
Yeah, we can. We can see the whole thing, but you're not on slideshow yet. You're just about to be, I think, when you click that thing down the bottom there.
Yeah, I have done that.
Yeah, I saw your mouse go there, but it didn't like it, did it?
No.
Maybe if you unshare and reshare, sometimes that. Oh, there you go. It's doing it. It's doing it. Go for it.
Temperamental. All right. Just let me move this out the way. Thanks, Elizabeth, for your kind introduction. I'm a CEO of the National Mental Health Consumer Alliance, and we are, of course, a proud member of the Consumers Health Forum. I'm delighted to join you today to talk about how discrimination, vilification, and bigotry prevent people living with mental health challenges to get the care that we need. The Alliance exists because mental health consumers deserve a strong, unified national voice, one that is grounded in rights, dignity, and lived experience. Today, I want to share what stigma and discrimination looks like in the lives of people seeking healthcare and what needs to change so people can finally get the care that they deserve. Before I begin, I acknowledge the traditional custodians of the land I'm joining you from today, which is the Gadigal people of the Eora Nation, and I pay my respects to elders past and present, and I extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. We acknowledge that this always was and always will be Aboriginal land. This truth really matters to us at the Alliance. It comes with our commitment to justice, to self-determination, and to work alongside First Nations people in all that we do. So for those of you who haven't heard of us before, the Alliance is Australia's national peak body for mental health consumers. We are the next chapter of a 50-year movement that has fought consistently and courageously for dignity, for justice, and for person-led mental health reform. Consumers have long called for a national voice that is strong enough to unite, not replace, the state and territory consumer peaks. A voice that brings together the depth of lived experience from every jurisdiction. It cuts through the silos and strengthens our collective impact. That vision became real when, as Elizabeth said, the Commonwealth Government recognised and funded the Alliance in 2024. So we're only 18 months old. Together under our federated model, we represent more than 8,000 members and 135 years of collective lived expertise across the country. We are many voices, one movement, grounded in the belief that people with lived experience must lead the systems that shape our lives. Everyone at the Alliance, including our staff and our board, lives with mental health challenges significant enough to reshape who we are. We lead from lived expertise. We know what works, we know what harms, and we know what must change. Unlike all members of the Consumer Health Forum, we are committed to consumer-led healthcare, rights-based reform, and the principle of nothing about us without us. So today's topic is about stigma and how it prevents people getting the care that we need. In our view, stigma describes harmful thoughts and often actions. To tackle stigma are focusing on educating people so they have a deeper appreciation of diversity. However, as most social scientists will tell you, it's way more effective to challenge people's behaviors rather than thoughts, because if you change behaviors, people then experience cognitive dissonance when their thoughts don't line up with their actions. And that then prompts a change in someone's opinions eventually. So the Alliance is instead calling out behaviours that can be observed, prevented, and acted on. Bigotry, discrimination, and vilification. So what do these terms mean in a mental health context? Bigotry is intolerant behaviour towards people living with mental health challenges, and it can happen anywhere. It might include jokes, small remarks, leaving people out, right through to acts of aggression or violence. Discrimination covers the unjust or prejudicial treatment of people living with mental health challenges in social life. So this includes being prevented from joining social events, gaining employment, renting a house, and a multitude of other behaviours based on the perpetrator's views about people with psychosocial disability. Vilification is public communication that stirs hatred towards mental health consumers. We face this regularly. Our annual human rights report shows that 8 in 10 Australians witnessed vilification against mental health consumers during 2024. For this webinar, I will use the word bigotry to cover those 3 terms. The Australian government is dragging its feet around bigotry as they apply to mental health. The National Stigma and Discrimination Reduction Strategy, which is a key commitment in the current Mental Health and Suicide Prevention National Agreement, it was developed and has been provided to government, but it has not been released. In the recently released Productivity Commission review of the Mental Health and Suicide Prevention Agreements, Recommendation 2.3 says that the Australian government should publicly release the National Stigma and Discrimination Reduction Strategy before the Mental Health and Suicide Prevention Agreement expires in June 2026. So we're giving them 6 more months. We call on the Australian governments to publicly release this strategy now without modification, delay, or dilution. We cannot wait while bigotry continues to harm us. And there is no nationwide binding Human Rights Act in Australia. There is limited guarantee that international obligations, such as the United Nations Convention on the Rights of Persons with Disabilities, are always honoured. So tomorrow, which is Human Rights Day, we are launching our first human rights survey, which has been created by and for mental health consumers. The results paint a stark and confronting picture. Across the country, people told us about the bigotry they face in almost every part of their lives, across the mental health system, in emergency departments, policing responses, housing, education, employment, child protection, and community services. Many described being treated differently because of their mental health challenges. Nowhere was this more evident than in our healthcare system. For many mental health consumers, being treated differently in healthcare means not being believed. This can look like having our physical health concerns dismissed or overshadowed by a mental health diagnosis. Over half of survey respondents reported that emergency services and health professionals failed to take our concerns seriously, especially when they sought help for physical health symptoms. Diagnostic overshadowing is a well-documented problem experienced by many mental health consumers, where physical health symptoms are incorrectly attributed to a person's mental health diagnosis rather than investigated on their own merits. When a consumer presents with pain, fatigue, neurological symptoms, or other health concerns, clinicians may prematurely assume these issues are psychological or stress-related, or a manifestation of the person's mental health challenges. This can delay accurate diagnosis, obscure underlying medical conditions, and erode trust between consumers and health professionals. The consequences are not only clinical, but also deeply personal, affecting people's sense of dignity, safety, and credibility within the health system. Diagnostic overshadowing is also a human rights issue. It undermines the right to the highest attainable standard of mental health, the right to non-discrimination, and the right to be treated with respect and dignity. When mental health consumers feel dismissed or invalidated, many stop seeking care, resulting in people enduring treatable physical health concerns. The cumulative effect is a health system that not only fails to meet consumers' needs, but also reinforces discrimination and exclusion. Across the country, people with mental health challenges continue to experience involuntary care and restrictive practices, including physical restraint, chemical restraint, and seclusion. Free and informed consent is fundamental in healthcare. It is an enforceable right. Yet mental health laws that allow involuntary treatment create discriminatory departure from these basic standards. Our survey revealed how widespread these practices are for people with psychosocial disability. Respondents told us about being detained, medicated, or restrained against their will, often at the very moments when they were most vulnerable. These experiences strip people of choice, control, and dignity, and they deepen fear and mistrust in a system that is supposed to support us. The numbers are confronting. Half of respondents told us they had avoided seeking support altogether simply to escape coercive practices like forced medication or threats of detention when in an inpatient mental health unit. More than a quarter of consumers agreed to treatment because they feared that if they refused, they would be subjected to involuntary treatment. At the heart of this issue is a deep-seated power imbalance. Too often, health professionals, such as doctors, psychiatrists, and others, are treated as unquestionable authorities. This leaves many of us feeling that our voices do not matter. Coercion thrives in environments where the provider is seen as the unchallenged expert, making it nearly impossible to question decisions or access real alternatives. Our respondents told us just how entrenched bigotry is towards people with mental health challenges in Australia. 86% of respondents told us that mental health is portrayed negatively and unfairly in the media. And an even higher number, 92%, said they had heard people with lived experience spoken about in discriminatory ways. The Alliance's Making Rights Real project found that our system often operates on a default assumption that people with mental health challenges lack capacity. This assumption leads to dehumanizing treatment and a disregard for informed consent. We heard reports of psychiatrists and other professionals dismissing people's concerns, providing medication without explaining its purpose or side effects, and hospital staff making disrespectful comments or jokes. These attitudes, this bigotry, create real barriers. They discourage mental health consumers from seeking help at the very moments when we need support the most. To help eliminate the bigotry that many mental health consumers continue to face, we are advocating for a National Human Rights Act. Currently, only the ACT, Queensland, and Victoria have human rights acts, and New South Wales and South Australia are considering developing ones for their state. So how would a national act make a difference to the way people with mental health challenges are treated? A National Human Rights Act would embed a human rights culture across the country. It would require courts to interpret all legislation in a way that is most consistent with human rights. It would require parliamentarians to consider human rights when passing new laws. And most importantly, it would place a clear duty on ministers, government departments, and public mental health services to act in accordance with human rights. This means they would have to demonstrate how human rights were considered in the way systems are designed, how services are funded, how workers are trained, and how care is delivered. When any of us seek support or treatment, the service itself, the staff, and the funding arrangements that sit behind that service would all have to comply with human rights. And if they don't, a Human Rights Act gives us a tool that strengthens the national framework and helps ensure our rights can be enforced. A National Human Rights Act would strengthen and reinforce existing protections. More importantly, it would send a clear message that the rights, dignity, and humanity of mental health consumers are not optional. They are fundamental and they must be respected. I want to leave you with one overarching message. Stigma is not harmless. It is not abstract. It is not a misunderstanding. It is our sector. In our sector, what people call stigma is often actually discrimination, vilification, and bigotry, and it shapes the care people receive every day. These are not individual failures. These are system failures, and systems can be changed. And they will be changed, but only if we act together. So I want to leave you with 3 concrete actions that every person joining us today can take away to help drive national reform. First is read and share the 2024 Human Rights Report, which is coming out tomorrow. This is Australia's mental health consumer-led human rights report. It documents systemic discrimination, coercion, and rights breaches in health, housing, income support, and emergency settings. Please share it widely once it's available with your networks, boards, clinicians, members, and policymakers. The more people who understand these findings, the harder they are to overlook. Second is to promote our 2025 Human Rights Survey. Change requires data, lived real-time frontline data. Every response strengthens the movement and builds the evidence needed for reform. So you can help amplify thousands of voices simply by sharing the link, and I believe the link will be shared in the chat. Finally, join the campaign for a National Human Rights Act. A Human Rights Act creates a baseline of dignity, safety, and respect across the entire health system. We are throwing our support behind the Human Rights Law Centre's campaign because when we speak with one voice, governments listen. And finally, I would like to invite you to join our movement, whether by signing up to our mailing list, amplifying our voice on social media, or if you're a mental health consumer, becoming a member of your state or territory peak. People with lived experience have always led the way because far too often our lives and well-being depends on it. At the Alliance, we are reimagining the future of mental health. We know the harms, we know the possibilities, and we know what must change. Discrimination, vilification, and bigotry cannot be accepted at the cost of seeking care. Let's build a system where every consumer is believed, respected, and safe, not by exception, but by design. And finally, we like to end all of our speeches by acknowledging and honouring the strength, insight, and leadership of all people with lived experience of mental health challenges. We recognise the deeper wisdom that comes from navigating systems, surviving harm, and reclaiming agency in the face of adversity. At the National Mental Health Consumer Alliance, we commit to centering lived experience, not just in name, but in action, ensuring that the policies, services, and systems that shape our lives are led by those who have walked the path. Thank you.
Fantastic. Thanks, Priscilla. You're getting a lot of love in. I hope you can see that. So do send your love to Priscilla and thank them for their presentation. Look at all of that there coming your way right now. You can probably stop the sharing now, I think. And then we'll go to Saba and Ali for their thoughts. So
have I stopped sharing or can you still see the presentation? Sorry.
We
I
can
can still see it, but sometimes it's a bit laggy when you stop sharing. You know, it takes a sec, but it's still there. Do you want to try and stop again if it'll let you? I know. Folks, tech. Gotta love tech, right? Show us with your emoticons what you think about tech. Get into the reactions. Do you love it? Do you hate it? What do you think? Makes you laugh? Scary? Want to blow it up? Well, no one loves it. Everyone here is either thinks it's crazy or I don't know what. Something.
I'm really sorry, but it looks like I've stopped sharing on my screen. Oh, hang on. Here we go. There we go.
Well done. Well done. Okay. I'm going to go to you first, Saba, and then Ali. Thoughts?
Perfect. I'm really happy and I'm looking forward to read the National Stigma and Discrimination Reduction Strategy, as well as waiting tomorrow for the results of the Human Rights Survey results. Now I know, because I live in a regional area, so I know again accessing mental health is such a challenge in a regional area. First of all, there is lack of the counselors, the health professionals, but also the stigma around it, because pretty everybody in the community know each other, so people always have a feeling that they will be judged. So that's another challenge. But also coming from the ethnic community, again, there's a lot of myths around that in case if you seek any treatment or attend any appointment, there is a chance that it will have an adverse effect on your residency, or maybe you might be deported. So again, I think we really need to work around all the myths around those, the questions which is there. But yes, and also what I feel is, on one of your slide, you did mention about that people are treated differently simply because they got their mental health issues. And again, which I feel is, I don't know why, but I don't know why people don't take mental health as just as a physical health thing. This is just one of the condition, and people can get treatment without without being judged. So yeah, very nice presentation, and definitely I'll be completing the survey. Thank you, Priscilla.
Thank you.
Ali.
Thank you. That was a really powerful presentation, Priscilla, that I felt really clearly articulated the injustices that are experienced by mental health care consumers, of which I've been one for over 15 years at this point. And so, like Saba said, I live regionally as well, so I found accessing treatment that I felt was helpful, and relatable, to be very complicated, especially as a young person. And that diagnostic overshadowing, that really hit home. Because, as I'm sure many other people here can relate to, I been very conscious about the context in which and to whom I disclose my history of mental health challenges, especially when I'm seeking healthcare, because I've experienced many times that dismissal of physical symptoms, especially neurological ones, as just depression and anxiety. And the fact that the just is in that phrase as well also speaks volumes to me. Like we are, what's the word? We're belittling people's experiences of those conditions too. So, yes, please, everybody, sign up to the campaign for a National Human Rights Act. This is something that many other organizations from a variety of sectors are pushing for, and collectively we can get our state, federal, and territory governments to recognize that this is something we not only want but need.
Fantastic. Thank you so much, Ali. Thanks again, Priscilla, and to Sarah and Ali for all of your terrific thoughts. Now we're nearly up to Q&A, folks. We've got 5 questions in the Q&A. So if you've got a question, now is your time to add it in, because in a moment we're going to start asking them. So something you want to know about, pop in the Q&A. Before we do that, though, I'm going to show you the results to that poll we did for question number 2, which said, okay, if this is a problem, how do you want us to fix it? So you might remember at the start we said, what would you like to be done to stop stigma in Australian healthcare? And here are the results. 70% of you said everything, all of those things would be good. We've got training for health practitioners, got a little bit more love than the other 2 when people chose just one. And people had some other ideas too, because 6% of people think there's something else that we need to do, that this is not enough just on its own. So we're going to welcome back our panel members now, who should all be on your screen now, and have a look at the questions that we've got in the chat. So thanks, Elsa, for your question. The first question we've got is, why we're using the word stigma at all when many people would see that this is direct and indirect discrimination. So Priscilla, you did talk about the word stigma and different ways that it's used. I might throw to you first and then see if anyone else would like to add to that as well, because Lucy, you used the word stigma in your presentation too. So maybe we'll start with Priscilla, then Lucy, and then if others want to comment as well.
Thank you. Yeah, like I said, our board has decided not to use the word stigma anymore when we're talking about the actions that other people do to us, because that leaves room for us to take action, and action gives us hope. So that's why we use those 3 terms that I mentioned in my speech. And the only time we really use stigma now would be when we're referring to some piece of work that has the word stigma in it, really. Yeah. I'll leave it there. Thanks.
Great. Thanks, Lucy.
Priscilla's really made me pause and think about whether we need to kind of move away from the term, because, I mean, stigma's the cause, discrimination is the impact, and we're here to talk about impact and changing outcomes for some really, really vulnerable communities. So it does make me think maybe it's a conversation I need to have with our board and our members about, are we using the right term here? Stigma can be a useful term sometimes when you're talking about self-stigma, particularly if you're thinking about cultural context of stigma for some communities. These are learnt attitudes, or there can be some practice that surrounds some of that thought. So I do think it still has use in some places, but yeah, I do like the idea of moving away from the term.
You've got your hand up, Priscilla.
Yeah, I think Lisa's just raised a good point about self-stigma. I've seen what governments have proposed doing or do to mitigate self-stigma. And I can only say that I'm disappointed. I think that when it comes to self-stigma, which actually what we would call would be internalized ableism rather than self-stigma, is something that personally, there might be a bit of disagreement here, is none of the government's business. I don't think the government should be meddling in internalized stigma or whatever you call it, internalized ableism. That is something that we do with our psychologists on a regular basis. And it's something personal and something that we've learned over a period of time. So anyway, that's my view. The government should not be involved in that.
Well, thanks. Thanks, Priscilla. Ali, I thought you wanted to say something here. I'll go to you and then Saba.
Yeah, I was also going to bring up internalized ableism being a term very commonly used in the disability community for what has today been referred to as self-stigma. And I agree, Priscilla. I don't think that that's something the government should be meddling in, especially when a lot of the time the causes and factors that drive the development of internalized ableism can be traced back to laws and policies that in turn have influenced society and, in that cycle of ableism way, have themselves been influenced by attitudes and unconscious biases that exist in society. So if internalized ableism is something that we carry, and for many of us, it's something that we don't necessarily realize the extent to which we're carrying it. It's something that we have to undo and unlearn not only within ourselves, but also more broadly as a society, continuing to understand and undo those attitudes and unconscious biases that help create an environment in which internalized ableism is given the chance to develop.
Thanks, Ali. Saba, you wanted to chip in too?
Yeah, so I agree with everyone, but again, I have a different prospect as well because I know sometimes it depends in which context you are using the stigma. Because I know sometimes in the promotional materials when I've seen the stigma, it's more like a correction thing. Because I know there is a chance that you might be coming from a different country. Things were portrayed in a very stigmatic way, and then arriving here, and then you feel that still it's not a stigma, but then it was previously a stigma in your back home. So there is a chance, yeah, sometimes the term might be coined in a very different way, or maybe yeah, it's the way it's portrayed in or used in some of the campaigns.
Great, thanks. Really, really great conversation. Lucy.
I just want to acknowledge Elsa's really good point in the chat that discrimination is a legal term with a remedy attached to it. And so sometimes I think maybe we need to get better at helping people identify when is it stigma and when is it moved into being discrimination, where actually some action could and should be taken because of the treatment that somebody might be receiving. So I just wanted to acknowledge that because it's a great point.
Great, thank you. We're going to get into another question now. I've got an anonymous question about cultural competency training, and there's a little bit of conversation about that in the chat as well, so I thought that might be interesting to explore. Ali and Saba, I'm going to go to you first this time, and then if Priscilla and Lucy want to join in, they're very welcome. And the question is, should cultural competency training be mandatory for health professionals and not just recommended? And if that's the case, what should it look like? So, Ali, I'm going to come to you first. What do you think what would help you with the health professionals you deal with? What kind of training or skills do you want them to have? Then I'll come to you, Saba, and then Priscilla and Lucy, if you want to make comments too, I'll come to you.
Well, when it comes to the training I would like healthcare professionals to receive, I'm a bit biased because I deliver this kind of training for a living, but I'd love disability inclusion training, as well as cultural competency training. the thing is, though, I don't know that making training mandatory necessarily creates an environment in which we start to see attitudes shift. I feel like when you mandate something like that, people end up treating it as a box ticking exercise rather than coming to it with their heart as well as their mind, and that genuine willingness to engage and do the work, both personal and professional, to create effective change. Cultural competency training, when it's done well and when you have people who are truly engaging with it, can be a transformative thing. But when it is just a once and done kind of date on the training schedule, then it might not be as effective as you intend it to be. That being said, though, I do think that some basics, especially when it comes to things like First Nations cultural competency and general cultural competency, just working with people who are different to you and being aware that, you know, we communicate in different ways and we have different contexts in which we're operating. And though you might not know or understand what those are, they exist. And here's how you can frame your conversations and the questions that you ask in ways that seek to gain that knowledge and understanding. That might be helpful.
Great, thanks, Ali. Saba.
So still, I feel that it should be mandated. The reason why I'm saying is because there is a chance that people are not aware or they don't have any prior knowledge of your cultural barriers, the challenges. And I'll quote my example. I'm very engaged in my community. I work with a lot of organizations, but still, when I joined health, so I'd worked in health before. So I was not aware of a lot of Aboriginal cultures until I did my closing the gap training, which is mandatory for me. I had to do it during my orientation. And then once I completed the training, I really felt on top of the world because I thought I knew everything. So still, and the thing is, if it was not mandated, there is a chance that I would not have done the training because it was recommended or optional. But I thought that that training really helped me in understanding the cultural barriers, the shifts, and everything. So again, having said that, I still feel that if you really need to understand any cohort, um, I know it might be a bit impulsive at times because if it's mandatory, there is a lot of things, thousands things to do at that particular time. But still, if it's mandatory, definitely you are going to do it at some stage of your life, and you will understand that particular culture, the tradition more. So I still feel, and again, I'm a very off example, but I know when people take Australian citizenship, they have to read a book. So I know you can ask any migrant who has passed the exams that they understand the Aboriginal flag, the history of Australia and everything, because they had to read all the chapters in case if they need to pass the exam. So I think it's really important to get embedded. I know time might be a factor, but I think it always helps.
Great, thanks. Priscilla or Lucy, did either of you want to make a comment? Priscilla, yes, go
Yeah,
for
I'm
it.
happy to jump in. I would like to see health professionals have to undertake two types of training. In the context of bigotry and discrimination, I think all professionals need anti-racism training because racism is a frequent form of discrimination, I think, against all health consumers, not just mental health consumers. The other thing I think would be useful would be social and emotional well-being training. So, in the mental health context, First Nations people see that as social and emotional well-being, which is a holistic way of looking at the whole person, and how that might lead to mental health challenges. If we can embed a social and emotional well-being framework within our health system, I think that will be much more successful than what we currently have, which is a very westernized way of looking at health. And it would work for everybody, not just First Nations people.
Yeah, great. Thanks. I'm just going to ask Lucy, did you want to add anything to this conversation?
Just to think broadly about what culture means in that context. So if you think about a prison setting, for example, there are some amazing community organisations doing work with people who work in prisons to help do some training around stigma, understanding bloodborne viruses, for example, understanding the culture around drug usage. So I think it depends on the context that people are working in. I also just wanted to very quickly address a question in the chat, which was around whether Hep B is a barrier to permanent migration. It's not. So that's determined according to how expensive your condition is, really. And these days, because Hep B can be quite simply and cheaply managed, it's not a barrier to permanent migration.
Great. Thanks. We're nearly out of time, folks. I'm going to throw around the group now and just ask you one question. It's a question that Amber's asked, so thanks for your question, Amber. Amber just asks, really, what's the most practical thing we can do now to resolve all of the issues we're talking about? Have you got one first thing, you bumped into Albo at a barbecue, goodness gracious, and he was listening to you and said, well, what should we do? But what's the one thing you think is doable or is the most urgent? You can define that however you like. What's the one thing? Let's get your sense of that. Who wants to start? Who's got a one thing that they're burning to tell us about? Go, Lucy. What's your one thing?
I think it would be providing treatment for Medicare and eligible people living with viral Hep.
Right.
They sit at the nexus of stigma and cost on that one, and it's a huge, huge barrier.
Right. So that's our one thing. Priscilla, what's your one thing?
Include consumers at every level: governance, implementation, co-creation, co-design. That's why the system isn't currently working, because we weren't included in what currently exists.
Nothing about us without us, right? Which has been, just for your reference, around for 500 years, that phrase. Saba, and then I'm going to come to you last, Ali.
Just in addition to what Priscilla has said, and engage with the rural and regional consumers as well, and making sure that the information is translated throughout the country, because sometimes, one size fits all does not apply, and our barriers and challenges are so different from the metro counterparts.
Fantastic. Ali.
One thing is very difficult for me, but come from a place of holisticness. I'm not wording that very well. Try and approach things as a whole interconnected system rather than addressing things in silos. And if I can submit one more thing, the National Human Rights Act, as someone has said in the chat.
Of course you can. How can I stop you? So we're nearly at the end, folks. Just a few minutes, a couple of things to do before we finish. First of all, let's give lots of love to our amazing panel, Saba, Priscilla, Lucy and Ali. How amazing are they? Hope you're soaking up all that love, folks. We'd like to do one more poll just to see if today's been helpful for you or not. So in a moment, we're going to ask you a question about how you rate your confidence in understanding this issue now. Would love you to answer with that. Let's give you a moment to do that. Fantastic. So before we wrap up, I'd like you to register for our next CHF talk, which I think if you're on this one, you'll really like the next one too. It's on mis and disinformation on its impact on preventative healthcare. It's a huge issue for all of us. I things that are being said that maybe aren't quite right, or maybe even deliberately distorting. It's on Tuesday, the 24th of Feb next year. There's a QR here. You can register. We'll put the link in the chat. We'll be putting it out in our newsletter and so on. So if you get that, you'll see it. But if you want to put the date in early before you go away, perhaps over the summertime, and completely forget that CHF even exists, I really like to thank the team at CHF who ran the session today so seamlessly. There's a heap of people whose faces you don't see. Carla and Nami and Emma and Ben, Tom, lots of people. So thanks to all of them for all of their support in making this work so well. And thank you all for joining us today. It's a busy year, it's a busy time of the year, and there's a lot for us to advocate for, as you've seen today. And we can't do our work without you, whether it's turning up to a webinar, being on a panel, or talking to someone at that barbecue, maybe not Albo, but someone else, about all these really key, important conversations that we need to have as a nation. But I hope that over the summer break, you get a chance to relax in some way. We leave the Zoom on for the next few minutes. So if you want to put anything in the chat, say goodbye to people or anything else, you're really welcome. We love feedback of all kinds. So send it along. Every time we do one of these webinars, we have a debrief. We ask, what can we do better next time? So tell us, what did you like? So we keep doing it. Or what didn't you like? So we stop doing it. Or what do we need to change? So we can do that too. So once again, a thank you to everyone. I hope you have a really great break, and we look forward to 2026 when hopefully we can make more progress on these really important areas. Thanks so much all.
Thank you, everyone.